There we go. Wonderful. Thank you. Good morning, everybody. I'm really looking forward to the discussion today and hopefully many discussions after that. So as I begin, here are the topics I want to cover in my short time. Obviously, I'm going to have to speak or very briefly cover them, but I want to say a few words about what we call the segregation model of research and practice, which is what's going on today. A few words about an integration model, what would happen under a learning healthcare system, something about comparative effectiveness research, something about the ethics of learning healthcare systems, and finally, I want to put before you an example, a counterfactual, actually, something that isn't what is currently the case, to see if we might later in the discussion start to think through with an example from oncology how we might construct an ethics approach to a comparative effectiveness study in oncology in a learning healthcare system. So all of those things in place. I have to always acknowledge my, I think of them as my partners in crime. What I say, this is the standard thing, what I say today that's bad is all my fault. What I say today that's brilliant is because I have the most amazing colleagues in the world. Nancy Cass, who is my co-principal investigator on the work that launched us on this enterprise, Tom Beecham, Sean Tunis, Peter Pronovost, and Steve Goodman, all of whom are truly, truly insightful people. All right, so let's begin with the segregation model of research and practice. I would submit that we're currently operating under something like a segregation model. And what I mean by that, what we mean by that is that currently our structure is determined, sort of founded on the commitment and the importance of segregating and separating research from practice. Understanding what is research, delimiting it, separating it from practice for a very important reason. I won't in this group rehearse the history. We know that there were powerful and important considerations, truly awful abuses of human rights in the 1960s and 70s that came to light in the 1960s and 70s. Many are still coming to light from earlier periods that made it essentially a moral imperative to figure out how to protect people from abuses in research involving human subjects. This very, very important moral imperative gave rise to a set of regulations and requirements. We're all familiar with them, the two cornerstone pieces: prospective IRB review, Institutional Review Board review, and prior informed consent. Now, when you have a regulatory imperative that requires that a certain activity be subject to prospective review, you have to be able to figure out what falls under the activity that needs to go for prior review, which means you need to have definitions and distinctions that segregate or separate research, which needs to go to the IRB, from clinical practice, which does not. And that's all I mean by the segregation model. We need to segregate research so that we know, right, what activities should go forward for prior review. Now, the segregation model, the current model, and I don't mean say, I just realized segregation sounds like a bad thing. Well, it wasn't originally. I'm thinking maybe it is now, right? And that's sort of the thesis of our view. The separation model, if we call it that, was terribly important and continues to be terribly important for purposes of protecting people from potentially harmful and abusive research and from more broad violations of human rights. However, over the decades, problems have emerged, and especially recently with that model. Now, there's been an awful lot of discussion of what many people have called the overprotection model problem, and that is the problem that the current system ends up spending a lot of time overseeing, quote, protecting people from research activities that are incredibly low risk. And that one of the downsides of that is that IRBs then don't have the time to properly attend to research that really is ethically problematic and that requires very careful scrutiny. So that's a problem that has been recognized for a long time. But there's a different sense in which the current system underprotects patients, not only in the sense that it doesn't allow, in some cases, for the most careful scrutiny because of resource constraints on the part of IRBs of high risk or otherwise ethically problematic research, but also because it's not conducive to addressing what are the more significant harms to patients, we believe, and the greater potential for abuses of patients' rights and interests in the current system than risks from research. And these are, and I don't need to rehearse this with this audience, but these are prominently, first, the significant problems we have today with medical error and patient safety. So without going through a ton of statistics, we can just sort of land on the one that several 100,000 people die needlessly each year from medical mistakes. That's just in the US alone. And the other piece of the problem, of course, is that we know that countless patients either get the wrong care or they get too much care or they get inappropriate care for lack of evidence about what the right care, in fact, is for that patient group. Now, I'm not suggesting, and don't want to be interpreted as suggesting, that the current regulatory system is the reason why we have these problems. Obviously not. These are very, very, very complex problems that have many, many interconnected causal pathways. But the underprotection problem that we're focusing on is the problem that emerges to the extent that the current regulatory structure makes it more difficult to generate the evidence, to find the solutions that will allow us to address these two very pressing concerns. Is everybody with me on the logic? I worry because I don't want anybody to think that I'm suggesting that the current regulatory structure for research involving human subjects is the reason we have medical errors or the reason that we don't know enough about how properly to care for our patients. It's rather that to the extent the current regulatory system makes it difficult, more difficult than ethically it ought to be, to address these problems, we have something that we can do something about. So the something we can do about this is what we refer to as the integration model of research and practice, which actually is in effect the learning healthcare system that has been promoted now for over a decade or almost a decade. And here's the classic definition or statement of what a learning healthcare system is from a National Academies, an IOM report. It's a system in which knowledge is so embedded into the core of the practice of medicine that it is that is to say, knowledge is a natural outgrowth and product of the healthcare delivery process and leads to continual improvement in care. So what are some of the features of a learning healthcare system? Well, one critical feature is that knowledge is generated from every clinical encounter. So every opportunity for patient care also becomes an opportunity for learning, for systematic learning. The learning that is generated is then translated back in a learning healthcare system into improved care in the settings in which the knowledge is generated and ideally more broadly. So basically the idea is a simple one: delivering care and learning systematically and rigorously from that care become the twin commitments, the twin and integrated commitments of a learning healthcare system. So you're committed equally as a learning healthcare system to delivering optimal care to your patients and to generating new knowledge at the same time. Now, obviously, a learning healthcare system can be directed at generating new knowledge of many types about many questions, but there are at least two that learning healthcare systems would be structured to address on a regular basis. And one would be, of course, how to improve patient safety. And the other would be to determine among existing clinical options which works best for which patients, effectively, comparative effectiveness research. Let me just say, as an aside, no fully complete learning healthcare system operates today. So we have some healthcare systems that are far closer to what we would understand as a full-blown learning healthcare system, but we don't have any quite yet. I tend to think of learning healthcare systems a little bit like human rights. We have progressive realization towards the goal of learning healthcare systems. We're on our way there, but we're not there yet. So what are some features of comparative effectiveness research? Steve has already mentioned a few. Here's another definition, a definition from another IOM report, which I won't read, about what comparative effectiveness research is. It is the case that CER today focuses primarily on existing, approved, and widely used interventions, typically routine interventions, generally low-risk interventions. But there's nothing about the sort of logic of comparative effectiveness research that need restrict it to low-risk interventions. Predominantly, though, the focus of CER has been on existing, approved, widely used interventions that are in routine use. And of course, the goal is to generate evidence that will help patients and clinicians and, of course, other stakeholders in the healthcare system to make more informed decisions and to improve care. To speak about comparative effectiveness research doesn't commit you to any particular design. This is an incredibly oversimplified way of setting this up, but you can have a comparative effectiveness research study designed many, many different ways. We can think of them in two big buckets, and those two buckets, of course, are not, in fact, exhaustive of all the designs, depending on how you think about research design, but you could have observational studies in comparative effectiveness research, and the key point here is however you design your observational study, no aspect of clinical care, no experience that the patient has is altered or changed by the research. Nothing changes. The physician and the other clinicians interact with the patient, make the decisions they would otherwise already make, and the questions are answered using data that are collected otherwise, generally for clinical purposes, sometimes augmented by additional data as well, versus randomized designs in which some element of the patient's care, some aspect of clinical care is determined by a protocol. And Susan will tell us, enlighten us about one of the most important approaches currently in CER, which is the pragmatic trial. So we'll hear about that one. We'll do a deep dive into that later in the panel. Now, our work, the six of us, has been focusing on first providing as robust a moral justification for the transition to learning healthcare as we can provide. And then secondly, putting forward an ethics framework to guide what we call learning activities, essentially research, in the context of learning healthcare systems. So we've put forward a framework. I won't go through each of these, but there are 7 obligations that we've identified that would form the basis or the structure or the ethical foundation for a learning healthcare system. We can go back to these later in discussion if that's of interest. We're now in the hard work phase of our program, which is working on determining how to develop from a framework like this the practices and policies that should guide the oversight of learning activities in a learning healthcare system. We're doing right now very extensive efforts in terms of engaging with stakeholders, especially patients, to get their views about how to understand what would be ethically acceptable in the context of a learning healthcare system. We're trying to build essentially from a foundation the sort of architecture that would be needed from an ethics standpoint to make a learning healthcare system ethically acceptable. One of the things we're focusing on in particular is to develop the sort of practices that any healthcare system would need to have regardless of what ultimate ethics framework they wanted to adopt, whether it's our 7 obligations or some other, that would make the work of the learning healthcare system ethically defensible. And these 3 are really critical. We call them our ETA framework: engagement, transparency, and accountability. By engagement, we mean that patients would be engaged, actively engaged in setting, and now we'll speak specifically about comparative effectiveness research, setting priorities for comparative effectiveness research, and patients would also not only be actively involved in setting priorities, but also in the ethics oversight of the studies that are determined to go forward because they are a priority, including the disclosure and consent practices that should be appropriate for a particular study. It's critical that a learning healthcare system be completely transparent to the patient community. They need to use a system would need to use multiple modalities to make sure that insofar as possible, patients can access what learning activities, what research is currently going on in the healthcare system, what types of patients are affected, whether there are any impacts on medical care, and so on. And finally and critically, a learning healthcare system has to be accountable to the patient community that it serves. It has to be able to explain and must explain to the patients what has been learned from the learning activities that were conducted in that setting, and also whether anything changed in healthcare in that setting as a consequence of the learning that took place. And if nothing changes as a consequence of a learning activity, why it didn't change. They didn't learn anything, or we learned something but we couldn't afford it, or whatever. So engagement, transparency, and accountability, key. Okay. So now I'm going to try to make all of this a little bit more concrete. And this is the counterfactual part. And here I have to thank Steve, because I was like, what do I do in oncology? Called Steve, and he was kind enough to help me think through how I might come up with a hypothetical for you all to think about that maybe we could discuss in the discussion that we'll have later. So this is an actual trial that Steve pointed me to that was conducted in 1996. The Eastern Cooperative Oncology Group reported results of a phase 3 trial comparing 4 different platinum-based doublet chemotherapy regimens that have been developed for treatment of advanced non-small cell lung cancer. Okay? Now, that's the trial that was conducted in 1996. And with all due apologies, as not even being a physician, let alone an oncologist, I'm going to pose a counterfactual here. I want you to assume that it's now, say, 2016, and that trial never happened. And all 4 of these regimens are now approved in wide use and considered comparable in effectiveness and side effect profile, but in the absence of any data about the comparative effectiveness of these 4 regimens. Okay? So this is the counterfactual. We still don't know which of these 4 regimens is actually better for this condition. I want you to imagine that there is now a learning healthcare system or several learning healthcare systems connecting large oncology practices. They have in place committees of patients and clinicians, in this case in lung cancer, who review requests to conduct different comparative effectiveness studies that come up from clinicians and from patients. They've determined, this group has determined, that conducting a study to assess, right, which of these regimens might work best for which patients is important and should be a priority. They are fully transparent, or as transparent as is possible in that group. They use listservs and web pages and alerts to inform their patient community of any learning activity, any research that's being conducted. And they're very conscientious about letting their patient community know about the results of any comparative effectiveness studies they do and whether they change practice as a consequence. So these are the assumptions. Now there are 2 options. The study could either be done with an observational design, in which patients and clinicians would determine which of the 4 regimens to pursue as they would otherwise. Nothing changes. And the comparison would be done using data from electronic health records. Or a randomized design could be used. And there are 3 options from the standpoint of disclosure and consent. And there's now a patient group that is advisory that will review these options for the 2 different designs and make a recommendation. And here are the 3 options. The study, randomized study, observational study, could just be implemented. The group could decide it ought to go forward, this group on which there are sizable numbers of patients and clinicians, that the study should go forward with complete transparency to the patient community, but nothing more. The second option is that the clinician would proceed with his or her patient as she would otherwise and discuss the treatment plan and indicate that she is participating, the whole system is participating in a comparative effectiveness study to see which of these other options is best for which patients. And if you, the patient, don't want to participate in the study, let me know. Otherwise, we'll proceed and assume that you do. And that would be done, that kind of exchange would happen either in the observational design or in the randomized design. So we're calling that the opt-out process. The exchange between the clinician and the patient would be essentially the same as would be if there wasn't a research component, except that the clinician would then go on and explain whatever the research component is and give the patient the opportunity to opt out if she would prefer from the research. And the last option, let's just simplify it, would be the traditional current informed consent expectation and process for research involving human subjects that would require the detailed consent form and the patient's signature before the research could proceed. So I'm going to stop with that and let you all think about it, and we'll go on. Thank you.